And it's 1 minute to go. So we can just like relax for a little bit. And then in 1 minute, we will see some people joining us for this session.
Do you see, because I'm not used to this program, so do you see the people? Or how does it go?
Yeah, so now we see the first people coming in because it's exactly 7:30. And so we're gonna wait a little bit until the room fills up. I think there's about I don't know, like 200 or something people that registered, maybe a bit more.
Really? Wow.
Yeah. Just Israeli physicians, yeah.
Really? Wow. I didn't know there's so many people who there are.
And,
so in Amsterdam, everything is now open. So are you totally open?
Yeah, of course, there's a lot of protocols in place. There's a lot of restrictions, but yeah, mostly we are open, and it's crazy busy. Like everybody, like it's been almost like everybody's been spending 3 months looking in the mirror and looking at their wrinkles and their folds and their sagging face.
Yeah,
they want everything right now, so we're very busy. Yeah.
Yeah. But I think it's not the same situation in Asia. For some reason, there is a slowdown. I talked to Ting Song and to other people. It's a little bit slower.
Mm-hmm. Yeah, I think so.
Yeah.
Too.
Yeah.
Okay, so we are at 63 participants right now. We can slowly get started, right? We can slowly get to what we're going to talk about. Let me just first introduce what we're going to do today. So this webinar was actually especially prepared for Israeli physicians, and it was I was actually inspired by Orit, and she said, well, you know, the Israelis, they're getting Xeomin in the market now, so and they really want to know the ins and outs of this product. They really want to know if there's any special tricks and any special ways that you use it, and could you, you know, if you want to have a subject for your webinar, maybe that would be it. Mm-hmm. And so I thought, yeah, why not? Why not do something especially for my Israeli friends? And yeah, so that's why we're here, and that's why I also asked you, Ofir.
If I don't meet you in conferences, so at least here virtually.
So what I understood is that Xeomin is on the market in Israel for only a few weeks or something, right?
Yeah. I've been trying it for the last 3 weeks. Actually, really, I was trying to really just try this product to see the difference. I have few patients that I didn't tell them, because I wanted to see if they notice any difference. Mm-hmm. And I think I'm going to tell you some interesting, because you remember we talked during the week, so I checked. Mm-hmm. So I have some interesting ideas.
All right.
But so do you know if all people who watch us, so they're all physicians, or?
Let's ask them. Let's ask. Okay, so I'm gonna start this poll. Wait, let me cancel. Let me go back up here. Are you a doctor? That's the poll. So I'm starting a poll right now. Are you an injector? That's the question. And you can say, well, I'm an aesthetic physician, I'm a dermatologist, I'm a plastic surgeon, I'm a dentist, because I know that a lot of dentists in Israel are injecting. Mm-hmm. Nurses, are there a lot of nurses?
No. Nurses are not injecting.
Oh, okay. And how about estheticians?
Estheticians, you're talking about cosmetician or esthetician? So aesthetic, so it's like you have to be a GP.
You have to be a doctor.
Or a dentist.
But if you have a nurse, is the nurse allowed to inject under your responsibility? No?
No.
Okay, but there's 3% nurses who are saying yes. So there are some nurses in Israel injecting. And let's see. So it's a nice distribution. It's about 1/3 is aesthetic physicians, like about 20% is dermatologists. The same is about maybe a bit less plastic surgeons. And 20% dentists. Well, there's 2% nurses, and 5% is not an injector. So maybe that's or Ilan from Alphametics tuning in. So yeah, oh yeah, and I was talking to Ilan as well, and he said what they really want to know is exactly the protocols. Exactly like like put a phase with some muscles and tell them exactly how many units they should put like in. So I prepared something, something how I use Xeomin, and also a little bit about the history.
So I think maybe we will start just by just saying, if we have physicians and we have nurses, so we're going to talk. We do lots of procedures, Jani. I'm sure you do lots of fillers and lots of energy-based device related or associated procedures, but botulinum toxin injection, this is probably the most common procedure worldwide. And I have to say that as compared to, let's say, other procedures, this is a procedure which is associated with very high satisfaction rate. So we're going to talk about comparison of Dysport and Botox and Xeomin, and we will try to see, but probably it doesn't matter what you do.
That's right.
It's like usually the people who go through this procedure, they're very, very satisfied. Maybe there are 3 drawbacks. I don't know. Just the longevity is between 3 to 5 months. It costs money. And you know what is the third? I think it's addictive.
Yeah.
I don't know. It's like
once you start, you never stop.
Yeah. So it's like dyeing your hair. So if you started, so it's like, so we're going to talk about the Xeomin, but just for the people who are less familiar with the botulinum toxin. So, we're talking about a potent neurotoxin. It is produced by bacteria. We're talking about Clostridium botulinum. We have different strain between A to G. And while talking about human, usually we talk about A and B. B is neurology, mainly neurology. So whatever we talk about, and we're going to mention many names, the generic and the commercial names, we're talking about botulinum toxin type A.
Type A, yeah.
Yeah. So it's like there are in the market, we have so in Israel, just for you to know, because it's different, we have Botox for many years. We have Dysport. And for the last, let's say, few weeks, we have Xeomin. I prepared some questions for you. So are you experienced with, because I know that you are a Meritz guy, so are you experienced with other non-Xeomin toxin?
Actually, you know what? I've been a trainer for both products. When I was a younger doctor, so yeah, I started out with.
You are younger. You're getting younger every year.
No, I have a good doctor. So yeah, I have experience with both products, and I have to tell you, once I switched from Botox to Dysport, I had a lot of problems in the beginning with dropping brows and stuff. So I realized that Dysport also has its own way of how to inject it. And I think also for Xeomin, there's a few little differences. If you're switching from Botox to Xeomin, it's not much different. But if you're switching for Dysport to Xeomin, there's a few things that you have to pay attention to. Otherwise, you may be disappointed sometimes with the longevity and sometimes with the strength of the effect. So there's a few things that I would like to get into during this webinar.
But in the last years, so do you focus on just Xeomin, or do you still have patients to whom you inject other toxin?
Well, I will get more into detail about why, but I actually do rather not inject the other products anymore. And there's a few reasons for this, but there's a few physicians, a few patients that really request Dysport. For example, for hyperhidrosis or Botox, because they're very brand sensitive, and it is they do pretty smart marketing, because Botox is usually a bit more expensive to buy, so they think it's more premium, and that's why they want that. But scientifically speaking, there is not really a good reason to not choose Xeomin.
Maybe for the Israeli doctors, because we are a small country as compared to all the other countries. So talking about the market in general, so I think Botox probably is the first one used, Dysport is the second, and Xeomin is the last one. But there are several countries in which actually there were changes. So in which countries, in your country, which brand is leading?
Right now, Xeomin is leading.
Really?
Is the biggest one, yeah.
When was the shift?
It was actually, Xeomin came on the market in 2011.
This is very important, by the way, Jani, to mention. I had a conversation actually yesterday with a doctor, and we talked about this webinar. And in Israel, it is considered new, but it got, so I think the first launching was 2009 or maybe even before, but there is a FDA clearance from 2011. So there are many studies. There is much experience with this Xeomin. To Israel, it got just recently, but we know a lot about this toxin, about the use of the toxin, and we're going to give you some tip and I want to start with that, asking you, because people are so used to Dysport and Botox. And probably, I'm sure you heard it, and this is very common question. Dysport, and we have patients who are actually claiming, they're insisting that Botox, this has a superior result, Dysport has superior results. So let's talk about efficacy. Okay, from your experience, efficacy. Let's talk about data, scientific data.
All right, let's do that. Actually, I need some slides for that.
Go for it.
So I just asked the doctors here, how much experience do you have with toxin? Like very many have like loads of experience. Between 4 and 10 is 34, more than 10 is 25%. So there's a lot of very experienced physicians here in the room. And there's one more I would like to ask, and that is, which brand of toxin do you mostly use? And the poll is live now, and I think I already see some people entering Xeomin. That is interesting. Maybe it's not just Israelis looking at this webinar, but let's see. Botox and Dysport are quite equal right now. And Dysport a little bit more.
This is the situation in Israel. Dysport, I think, again, it's not, this is my, but I think Dysport is the first one, and it is followed by Botox, but they're quite the same. And Xeomin, but again, this is it's just the beginning.
So now we have about 1/3 Botox, like 50% Dysport, and about 20% Xeomin. It's quite a lot for a brand that just entered into the market. Anyway, all right. So,
efficacy, Jani.
What's that?
Efficacy.
Efficacy. Yeah.
Is it the same?
Well, there are a few differences. Let me just quickly start my presentation. So I'll just share my screen, and I will go to the keynote. All right. So, of course, you know me, you know Ofir, and let's talk about botulinum toxin A. And the funny thing is that there's this German physician, Justinus Kerner, and he was the first one. It was like in 1857, I think, when he published this paper on the spoiled sausages, where the people were getting after eating the spoiled sausage, they were getting all these paralysis disorders. And he already said in his early paper that if we could purify that thing that caused this paralysis, then we could maybe use that agent to treat hypermotility disorders and spastic disorders. And the funny thing is that when you look at this guy's face, you see this big glabella. So maybe that was his kind of inspiration to think about something that could relax the muscles. And of course, like you said, is Clostridium is like a dipeptide, is a light chain and a heavy chain, and together they're botulinum toxin type A. small video. I don't think it's really necessary to
No, I
show
think
the mechanism of action, but it's funny that I'd like to show you this one, that the market share of Xeomin in Benelux when it was introduced in 2011, of course, 0%, but then 2017, 35%, already market leader, and now 40% of the market is very steady leader of the market. And right now in Israel, it's Disport is market leader. So I'm very curious how that will go as time will pass, and of course it has to do with the science, and of course it has to do with the marketing, because we are physicians, we are sensitive to marketing, and of course it has to do, of course, with the price. But I think medically speaking, there's a lot that we can say for Xeomin.
Mm-hmm.
So you were talking about efficacy. Well, if you look at the differences between these products, right? Over here you see that Dysport is abobotulinum toxin A, that's a scientific term. Xeomin is Inco, and Botox is ONA, botulinum toxin A. And they all have the same active ingredient, but they have some different additionals in the product. And what is really, really different is the amount of total clostridial protein in the vial. If you look at Dysport, it has 4.35 nanograms per vial of 500, whereas Xeomin has 0.44 per vial of 100, and Botox has 5 nanograms per vial of 100. So there's a huge amount of clostridial protein in the other formulations. And then there's this strange units calculation. You know that if you switch from Botox to Dysport or vice versa, then all of a sudden you have to recalculate the units. And the interesting thing is, why do you think that is? Because the units that we use are LD50 units, right?
Mm-hmm.
So that means with 1 unit, 50% of the mice that you inject into the abdominal cavity, if you inject 1 unit into a mouse, into the abdominal cavity, then 50% of those mice will die. That's the LD50 assay, and that means that 1 unit is that strength. So also with Dysport or Dysport, that is the same calculation for the units, but somehow you need much more units, 2.5 times more units, to achieve the same clinical result. There's actually a reason for that, even though potentially you can kill 2.5 times more mice with the same amount. And this is the big difference, the complexing proteins, right? So there's complexing proteins in the older formulations, but 0 complexing proteins in Xeomin.
But maybe, Jani, just one, because the table, just to make it more simple for the people who are less familiar. So while talking about, for example, Botox, so 85%, it's what we call complexion, or this is the complexing protein. This is 85 of the toxin. So actually there is no role for these complexing proteins.
Mm-hmm.
And we have 15%, which is the neurotoxin. And out of the, I would say 15%, we have 16%, which is the active protein.
Mm-hmm.
Okay, and 40% inactive protein. And you are talking about the protein in general.
Exactly. So this is a little bit more of a graphic representation. If you take, for the glabella, for example, if you take 20 units of Botox, then the red is the amount of botulinum toxin, the neurotoxin, the red,
Mm-hmm.
the red, right? 50 units of Dysport, the red is 50 units of botulinum neurotoxin in Dysport. And the blue is the total amount of clostridial protein, including the complexing proteins. So as you can see, Xeomin has the lowest bar. The red one is the same as the blue one, which means that total clostridial protein is exactly the same as the amount of neurotoxin. That means there's only neurotoxin and no other clostridial protein, because these bars are the same height.
And this purification is actually it's happening during the manufacturing. So they just remove the what we say unnecessary proteins.
Exactly. So, and actually, I know the guy who invented Xeomin. His name is Jürgen Frevert, and he used to work for Allergan. And he told me that once he went to the management and he said, "Listen, guys, let's try and make a pure botulinum toxin. You know, we call it Botox Pure or something." And he had an idea of how to do it, and they refused, and they said, "Well, we don't believe that it's possible." So they didn't invest the money.
Mm-hmm.
But then, of course, Merz was very interested in his idea, so they hired him to do it, and he pulled it off. He made a neurotoxin free from any other bacterial proteins.
Mm-hmm.
So if you ask what's inside, what bacteria we use for the production of these three different products, it's actually all the same original bacterium. So there's a specific strain of Clostridium botulinum, which is called the Hall strain, and from that Hall strain, they produce their product. So in the production process, there's a few differences. And Botox and Dysport have inactive neurotoxin, and that is what is in this chart. You see that the red bars are higher than the red bars in Xeomin, and it's because there's not just active neurotoxin, there's also inactive neurotoxin. So these complexing proteins, they are in Botox and Dysport, and they have no pharmacological reason to be there. You don't need them. You don't need them to protect the toxin. You don't need them to stabilize the product. There is no inhibitory effect on botulinum diffusion and no role in the mode of action. There's a few differences. Dysport contains less albumin than Xeomin and Botox. And the interesting thing is, it is a mistake in the production process. And Ipsen has chosen to not increase the amount of albumin, because then they'd have to go through all the different studies again and the trials for the FDA, etc., to get that registered. But if they would have increased the amount of albumin, then potentially one vial of Dysport could be the same as 500 Allergan or Merz units. And that is because they didn't put enough albumin in the vial. And albumin has a competitive sticky, is a competitive sticker, which means that proteins, if you put them in a glass vial or in a plastic syringe, they have the tendency to stick to the side, to the wall, the inside of the wall of that vial or that syringe. So if you put more protein in that solution, there's a competition between sticking to the inside of the vial or the syringe, so you don't lose the units to the inside of your syringe.
Mm-hmm.
So there's lactose, sucrose, and NaCl. I don't think it matters a lot to see in these formulations. But what is an interesting observation, if you use, let's say, the 2.5 calculation for 1 unit of Xeomin or Botox versus 2.5 units of Dysport, and you measure the anhydrotic halo in the forehead of a patient, you see that Botox and Xeomin are exactly the same. They have exactly the same diffusion radius. Whereas Xeomin versus Dysport, then Dysport has a larger diffusion radius.
I don't know if this is the study you're referring to, but there was a study by, I think it was Kircher.
Yeah, this is the one.
This is the one? Okay. And actually, I think Botox and Xeomin, they were the same as compared to Dysport, in which the diffusion or the spread is higher.
Yeah, and the interesting thing is that if you think about it, you know, the Xeomin is 150 kilodaltons, right? A small protein, whereas Botox is 900 kilodaltons. So how do you explain that the diffusion radius is exactly the same for these 5 units that they injected? Ofir, are you there?
Yeah. It was a question?
Now the question is, so there is 5 units injected of Botox and 5 units of Xeomin, right? Intradermal. But Xeomin has 150 kilodaltons, whereas Botox is 900 kilodaltons. So why do you think there is exactly the same diffusion radius?
I have no idea. What is the explanation?
Well, this is the explanation. So the diffusion radius of Xeomin, 150, is exactly the same as Botox, right? If you use the same amount of units. And even though there is a huge complex versus a small protein, so the diffusion is not dependent on the size of the complex size, but on the amount of units. And it's because of the fact that, where is that slide now? Wait, let me see. I've defined that slide. Here we go, this slide. All right. What happens if you reconstitute Xeomin or Dysport? Sorry, if you reconstitute Botox or Dysport in your vial, you put saline there, then pH becomes, physiological, and then within 1 minute, the complex dissociates from toxin.
Mm-hmm.
And that means that once you inject, then you have no more complex. There is just free neurotoxin and free-flowing complexing proteins. So Botox and Dysport do not contain any of the 900 or the 500 kilodalton complex, because within 1 minute after reconstitution, there's a complete dissociation of these complexing proteins from the toxin. And that means that Xeomin looks like this, nice and blue in a vial, and the same nice and blue toxin is also present in the other products. But in the other products, there are all the additional proteins that are there. So this is from a recent study from Kerscher and Rangzima and Ada, and also Frevert was involved in this one. So you can see here that this 0.44 per 100 units of, this is I think nanograms of toxin. And then in the other products you have inactive botulinum neurotoxin. Mm-hmm. And of course, total clostridial protein, which is much more than is necessary to get that desired outcome. Now, here is your question, your answer to your question. How about efficacy?
No, wait, but regarding the distribution, so more protein, it means more osmosis of water within the tissue, and this is the reason you have more diffusion. This is the reason. So, what is the actual reason for the diffusion of the higher diffusion in or spread in Dysport?
Yeah. So the reason is that actually the diffusion radius is dependent on the moment that the toxin binds to its receptor. So as soon as the toxin is stopped by binding of the toxin to the receptor, so there's like, if you look at the presynaptic membrane, then there's the synaptic vesicle 2 receptor there, and inside the synaptic cleft. And that's the target for the neurotoxin. So as soon as it binds, the diffusion stops. So if you look over here to the Dysport side, you see that the anhydrotic halo is larger than this one. That means that there is probably a higher dose injected compared to the other side. There are more molecules injected on the Dysport side versus the Xeomin side.
Okay.
So the units calculation is incorrect for the forehead, which means also that if you use a certain amount of units for Dysport and you think, okay, let's just divide it by 2.5, then maybe you're not injecting enough units. Does that make sense?
Mm-hmm.
So maybe it's, instead of dividing by 2.5, maybe it's dividing by 2. For the forehead. For the glabella, it's been very clear. So there's 50 units of Dysport and 20 units of Xeomin or Botox. All right, so efficiency, longevity. So this graph really represents the longevity, and these are hundreds of patients included. So what you see is that these graphs are almost identical between Botox and Xeomin, going like how fast they come up and how long they last and how fast they reduce.
But I can see that this is for neurological, probably because it was, it was published in
Yeah.
a journal of neurology.
Yeah.
But I think we do have, so for the aesthetic market, we have studies by Sattler and Prager. So they checked the efficacy of diasporic Botox and Xeomin for the glabella, and afterwards for the crow's feet, even for the platysma. So we know is the same. So efficacy is the same.
Exactly. It's exactly the same as Botox, basically. But okay, so now
so I have a question.
Yeah.
So if it's the same and if it's the same price, why using Xeomin?
Well, I will tell you a personal story about my assistant. Her name is Sitska, and before she was my assistant, she was my patient. And she was young. She was like 24 or something when she came in for the first time, and I injected some toxin, and it was Botox at the time. And I think it may have switched to Dysport, so I injected both products on her, and then she became my assistant. And then I noticed that after a few years, she became kind of tolerant. She actually developed tolerance with Botox and Dysport, and after 5 years of treating her, I needed 100 units of Botox, and it only lasted about 2 months. And it made me realize that even though there's no, not real non-responder, but there's a gradient towards a full non-responder. And I was thinking back to my patients, and I realized, and maybe this makes sense to you, Ofir. Have you ever had a patient that asked you, are you diluting the toxin?
Mm-hmm.
Are you using a lower dose? Because
yeah,
the feeling,
or are you using water?
It's not as strong as it used to be. Do you have these patients?
Yeah, but the scientific data, we know that when we re-inject botulinum toxin, there is a study from, I think, New Zealand. It was on rabbits, and they showed that we have neutralizing antibodies in, I think they showed in the rabbit it was 20% for Botox or for Dysport. So we do know that this phenomenon is actually true. And I have to say that it's like, I think that there was another study in humans. I don't remember the name. That's where you're showing. So, okay. So we see that we read the same papers, but there was even a study in humans, and I think the numbers were it was less. It was like 13% or something.
Mm-hmm.
But we do know that there is this concept of phenomena. Though I have to tell you, Jani, that it's like whenever a patient is coming to me and he's telling me he's not responsive to botulinum toxin, usually I question the dose and the technique. But
exactly,
you're right.
So, and so I switched her to Xeomin, and I kept on injecting her, and she became a full responder again, needing only about 50 units, which lasts 3 to 4 months.
So what you're saying, so just for the people who are less again familiar with the subject, so what you're saying, so we have a complexing protein, and actually this is the cause. So this is this will provoke an immune response, and in the end, we will have two types of antibodies: the neutralizing and the non-neutralizing antibodies. And eventually, if we have those complexing protein, we have higher chance of having resistance. That's what you're saying. Absolutely. So you're answering me that the reason for using Xeomin, that there is less chance for, this is the reason. Okay, so this is one, good reason. But most of the patient, they do not really develop resistance. And they're very happy with Botox or Dysport. Any other reason to switch?
Exactly. So I think this for me is a very important reason, because we have Xeomin, and it has no risk of immunogenicity. So why would you use a product that does have that risk?
It is true. Plus, I always say we actually in my hospital we investigate this molecule, and I always say that we know what we know about this molecule. We might know what we do not know, but I think in general we do not know what we do not know. So it's like maybe if you don't have to use this protein which stimulate an immune response, why using it? Yeah, I fully agree with it.
Exactly my point. And if you think about it, if we have clinics, so we try to get our patients in the clinic in an earlier age. We're talking about prevention of wrinkles. So we get them in, and their friends bring them in, and they're like in their 20s. And then we want to keep them with us. We want to inject them every 3-4 months, and we find new indications. We find the masseter, the platysma. There's all these agents are injecting all over the body, reducing the deltoid, the gastrocnemius muscle. So they're starting to inject this huge amount of toxin per treatment. And so basically what we are doing is like that study that you mentioned with the rabbits. We are giving our patients a vaccination program. So that tolerance and that resistance is real, and we are seeing more and more patients that are starting to become not non-responders, but reduced responders to the toxins that we use, except Xeomin, because Xeomin shows that there is no increased risk in immunogenicity. So that is a good first line choice.
There was another study that it's very interesting to mention if you do talk about responsiveness. So it was a study, they took 14, I don't remember who was the author, but they took 14 patients who stopped responding. So they claimed that they do not have any response to any other toxin, and the physicians switched to Xeomin, and what they showed in the study that 10 out of the 14 they actually started responding, and 4 had some response. So it wasn't the switch wasn't fully, but still we have some. So if again this is an answer, if we have patients who do not respond to other toxin, Xeomin, it is the answer.
Yeah, so this is probably the study that you're referring to, the Hefter study. And you see here all these lines over here. It's a bit complicated graph, but these are all neutralizing antibodies measured in the serum of the patient, so in blood. And so they're all secondary non-responders to Botox and Dysport, and they had high neutralizing antibody titers in their blood. So they were switched to Xeomin. They kept on being injected every 3 months. And even though they were repeating the injections with Xeomin every 3 months, they saw a gradual decline of all these patients. So even though they kept on putting that foreign protein inside the patients, there was definitely a decline of antibodies until below detection.
Yeah.
Then let me see. Just to show you that in the past, both Allergan and Ipsen have put lots of investment into reducing the amount of bacterial proteins in their products. And in 1995, this was the amount of protein in Botox. And today, this is the amount of protein in a vial of Botox. So they already have invested in purification of their products, and the same is with Dysport. And of course, the new kid on the block is already pure.
Maybe for the people, again, who are less familiar with the subject, you have to understand that we know that with long-term use of toxin, we have, this is a study by Albrecht, and we do know that we have above 13% of the patient that we do find neutralizing antibodies. So this is a fact. Okay, maybe they do not stop responding to the toxin, but these neutralizing antibodies do exist in above 13% of the cases.
Yeah, so that for me is probably the most important reason to use Xeomin, because we don't put that risk onto our patients. And of course, there's other reasons. You don't have to put it in the refrigerator. So, and also for the transportation, it doesn't need to be refrigerated. It stays active even after reconstitution for a year. Doesn't lose its efficacy, although in the instructions for use it says that you should throw it away after, I think, 24 hours or something because of sterility issues. But you know, the toxin is very, very stable. It stays active for 1 year, 100%.
Maybe another thing regarding the antibodies, you know, we know it was reported in the literature. We do know that we have, and actually I have few patients who claim to have flu-like syndrome after the injection of botulinum toxin, and it was shown, probably again this is because of the antibodies, or maybe not the antibodies but the immune response. And we do know that when you switch to Xeomin, and again, it was shown in different studies, you actually do not have this flu-like symptoms. And again, this is important. I think, by the way, the reconstitution and the storage is very important. So you actually, you know, you just said it in one sentence, but it's like if a physician doesn't have a big clinic, and he doesn't have lots of refrigerator, or if he wants to, you know, to take the toxin from one place to the other. So I think this is an advantage. Can you explain why? So why, for example, the other companies, they have to be refrigerator as compared to Xeomin? So what is the
Yeah, it has to do with the production process. You know, it's a lipophilization. So instead of having like this, let's say, film on the bottom of the vial that contains the toxin, it is kind of a cake. And apparently that is enough to be stored at room temperature and remain stable. And actually they did a test and it remains stable up to 60 degrees, you know. So if you have your clinic in Israel, like somewhere in Eilat or something, where it can become really, really hot, or near the Dead Sea or something, then yeah, still until 60 degrees Celsius.
A little bit more than 15 minutes. Let's we talked about so of course, so I think we convinced the audience that the efficacy is the same and Xeomin has advantages. Let's be more sexy. Okay, so let's give them some tips and pearls. So talk in few words about reconstitution. Do you have any tips and pearls? And then we're going to talk about different indications and different secrets.
All right, cool. Okay, so just real quickly about reconstitution, and that also has to do with can you see my slide?
Yeah.
Okay, good. So when you reconstitute Xeomin, you have to invert the vial. This is really important because, as you can see over here, some of the toxin is inside the rubber cap. And if you just put the saline in and then use this solution, you are not using the units that are in the cap. So you have to turn the vial upside down. So basically what you do is you take 2.5 milliliters of saline. And I think it's important to really use 2.5, because all the studies were done with 2.5, and it's just the way that you use it. And there is really no difference. I mean,
do we have just 100 unit vial, or we have 50?
This is for the 100 unit vial.
Okay.
On the vial, it says Beau Couture, and that is actually the European brand name for the aesthetic Xeomin. So, but this is Xeomin aesthetic. And so it's 2.5 mLs per 100 unit, which gives you 4 units per 0.1 milliliter. So if you're used to Dysport, then you would inject in volume about twice as much. So instead of using 0.05, 0.05, 0.05, you would inject 0.1, 0.1, 0.1. That's a difference. It allows you to work a little bit more precise.
Okay.
Get a little bit more of a bump, but that bump goes away. And you see, I'm inverting the vial right now. I'm really putting the saline all the way to the bottom, and I'm rotating. So I'm making sure that the saline touches everywhere within the vial. And this is something that is really important when you buy Xeomin, and Alphamedics also has a very important role here, is to explain to the physician, please invert your vial when you reconstitute. We're not used to this when we make a switch. And this is actually what in a lot of countries has caused some, let's say, frustration, because people thought it was not as effective as the other products.
And we have to emphasize that after you reconstitute, it has to be refrigerator up to 1 month.
Yes, yeah. After reconstitution, we have to refrigerate. That's right.
Yeah.
All right, so let's talk about treatment techniques. What do you want to talk about?
So let's go over the indications, and I want to hear actually. Let's see if you have anything new to. So glabella. Let's do it quick. Glabella with the Xeomin. What is the exact dose? Is it like Botox?
Yeah, that's pretty well established right now. Oh wait, that's not glabella. Let's see, where is the glabella now? Actually, the forehead is probably the most interesting.
All right, so let's start with the forehead.
Let's see, where is that? Is this a forehead? No, this is auricularis. Where is the forehead? I have the forehead right here. Okay. All right. So you see that the black dots here?
Yeah.
These are typically where you would inject Dysport, right?
Mm-hmm.
Do you inject Dysport or Botox?
I inject both.
Both, right. And you know that these red ones, these are the ones where with Dysport, you have to be really careful, right? Mm-hmm. With Botox, it's a bit easier to inject here. You just make sure that you're not injecting too deep. And it's actually kind of the same as with Xeomin. What's important with Xeomin is that, first of all, you have to inject in the muscle. I know that a lot of us are injecting subcutaneously or maybe even intradermally, but with Xeomin, it's an intramuscular injection. If you just inject over here in the black dots, then you already can get a very good result. And it's not for nothing that we've decided to put 3 injection points per side, and it has to do with the fact that the frontalis muscle has 3 areas where there is the highest concentration of neuromuscular end plates. So we're actually, based on the anatomy, that is a very good way to inject the toxin because it's very close to where the receptors are. Now,
3 questions. Again, tips and pairs. 1, do you use the same dilution, or in certain patient you hyper dilute?
I'm coming to that one. I'm coming to that. Wow, man, you know so much, bro.
We have to. We don't have much time.
Okay, all right. So yeah, so the normal treatment technique is this. Right, I'm just gonna fast forward. So basically, you know, these 3 injection points, right? And
the middle one is the mid papillary line.
Yeah, and so I'm giving, you know, like intramuscular injections in each point, and that already gives a very good result. And in her case, I injected 4 units per side, so 8 units in total, and she could hardly move her brows. So, and then this one, very, very careful. This is very superficial, because if I go too deep here, then I really could drop her brow, right?
Again, to emphasize, it was described by a few physicians in the past, what we call it's not just with Xeomin, it's the multi-layer technique. So we inject into the muscle, or we inject into the subcutaneous or intradermal. It's not just with the forehead, but please pay attention that the upper injections are intramuscular, and actually the lower one are intradermal, if I can say it.
Yeah, maybe this is an intradermal bleb. Yeah, you're
Yeah.
right. Yeah, and that is just because I want a little bit mild effect there, right? So choosing the injection depth can also give you a strong or a weaker effect.
Mm-hmm. Another question. So this is an easy patient. So if you have a man with not valleys, he has a very, very deep. Do you combine with fillers? Do you do it the same treatment? What is your approach?
So with men, I often use the Grid 21 protocol, and I'd be happy to share it. You just have to let me see. I think most of you guys can contact me. This is the Grid 21 protocol. There's a book coming out very, very soon. I think it's in the next few weeks. I'm publishing a book on neurotoxin techniques, Xeomin techniques, and the Grid 21 is designed for Xeomin. So based on the muscular strength, you inject a certain amount of units. So you see all these colors here in the forehead. These represent based on what I feel with my hand when I ask him to lift his brow. So the red is 2 units, the blue is 1 unit, and the green is 0.5 units. And so based on what I feel, I give that patient a specific amount of units. And so there's 7 vertical lines and 3 horizontal lines.
This is quite a strong muscular pool over here. So over here, I will inject 2 units in that medial lower part. Then the right side, I'll start on the medial side of the right side. Can you raise again and relax? And I'll put a bit more pressure, raise again and relax. Okay, so here I have to put also quite a lot of pressure. Raise again. But I don't want to drop his brow, so I'm just gonna start with 1 unit over here. So it's a blue dot, 1 unit right there. Raise it.
So it's becoming a very individualized treatment. So it takes some time to mark and to plan, but eventually you have a very, very nice, efficient way of putting the amount of units depending on the strength of the muscle. And then it's, then it's a matter of just injecting.
So I have, it's actually a similar technique, but what I do, I hyperdilute the toxin, and I have multiple injection points. So from upper to lower, so the upper ones are intramuscular, and the lower I get, I'm going more and more superficial. But in the forehead, as compared to what I was taught in the beginning to have, I don't know, 4 or 5 injection points. Now I inject lots of points with the hyper diluted toxin. And again, here I don't see many wrinkles, but if it's a wrinkled guy or a woman, I inject fillers in line the same treatment. All right, so enough for the forehead. Let's go to the next indication, glabella. Okay. Anything interesting, or we can just carry on?
So one interesting thing is, and I made a little joke because what is more attractive? What is a beautiful toxin result?
It has to, first of all, it is beautiful, so I have to say it, but it's like I really like when you have a very pleasant appearance and not too dramatic and too extreme. This is a bad, this is Nicole Kidman, right? So this is a bad toxin, and yeah.
So patients demand a natural result, right? They want to have a natural result.
Yeah.
And I have basically 2 types of patients. One is saying, I want it to last as long as possible, so maximize the dose for me. There's another patient who is extremely afraid that she's going to be looking unnatural. They want a natural result. Of course, they also want it to last, but then of course, then you get into that conversation, right? If you want to be able to move your brows, if you want to be able to frown a little bit, then it's going to last a shorter time. Xeomin, and this is a Botox study, so it shows that 10 units of Botox lasts shorter. It has a less of an effect, with maximum frown is about 80%, whereas if you inject 20 units, you have 100% reduction in maximum frown. And of course, with 10 units, it also lasts much shorter.
Mm-hmm.
So every if you have every 4 months, you have maximum frown goes up to 100, then it goes down to 4 months to about 20%, then you re-inject. So it's actually going up and down, right? So with Xeomin, you're allowed to inject every 6 weeks. Is the only toxin that you're allowed to inject every 6 weeks. The other
because of the lower risk of
exactly immunogenicity.
Okay.
Yeah.
All right.
So if you look at the instructions for use, it will say you wait 6 weeks and then you can re-inject, whereas the other ones you have to wait at least 3 months, 12 weeks, I think. And so there's a few patients, and that's only possible with Xeomin. You can start playing with baby tox, and so low doses, and then you will see that they're coming back a little bit earlier. You tell them, come back, but we keep it natural. And then your graph is going to look like this. So instead of getting all these peaks and valleys, you have a more stable and very soft result.
It's actually a very nice idea, but we do have to emphasize that you have to tailor your treatment according to what you see on your patient. So there are few publications regarding the type of glabellar injection. There is U and V and omega and inverted omega. So we're not going to get. We're not going to get in. You sure you prepared it. We're not going to have time for it. So you can read the publication, but again, you have to customize your treatment according to what you see. CrossFit, any tips and pearls?
Well, I think one nice thing is what I like to do with the orbicularis oculi muscle, and I briefly showed that slide, was actually injecting it like this. And of course, with the normal treatment protocol, you can of course inject the crow's feet like this, with the in the tail of the brow to get a little bit of lateral lift, and then the lateral injections for really reducing the crow's feet, and these very, very superficial low dose injections over here to reduce the wrinkles in the lower eyelid. But what I like to do is also and of course the brow lift, what I like to do is also inject very close to the lashes. And actually these dots should be even a little bit closer to the lashes, because with that you can give a very nice opening of the eye.
The idea is that the eye...
And so what we want to do is we want to give her a little bit more open look. And so that is where we will be injecting. And as you can see, it's only going to be twice half a unit that I'm injecting. So as you can see over here, just a little blab over here and just a little blab over here. And that will give a very subtle relaxation of the orbicularis oculi muscle, opening the eye.
Mm-hmm. Yeah, this is a nice indication.
So that, but of course you can do that with all the toxins. So it's not special for Xeomin. But what is special for Xeomin is actually this one. And this was based on what Rangzima from Bangkok has taught us in her in vitro studies, studying what effect neurotoxin has on the fibroblasts. And this is a completely new idea. And she showed that if you have some fibroblasts in a Petri dish and you put some neurotoxin in that Petri dish with the fibroblasts, these fibroblasts start to contract. Mm-hmm. And found out that the ideal dilution for Xeomin is 6 milliliters of saline per 100 units. That gives the fibroblasts the maximum contractibility. So we don't have any data, published data on in vivo use of this, but you can, and these are all intradermal injections, and she's calling it microtox. So she's doing all these injections all over the lateral part of the face, and you can also do that in the forehead. So it's like little blabs, and this is hyper-diluted Xeomin. Off-label, but the nice thing is you get a very nice and even result. And I think I injected 12 units in total, so 6 units per side in this patient.
This is Rungsima or yourself?
Sorry?
This is exactly what I do. This is Rungsima or yourself?
This is me injecting.
Yeah, that's okay.
Yeah.
By the way, regarding the fibroblast stimulation, I'll show you, I prepared some slide. I do use it, especially for the neck area. I reconstitute it with the radius and with the dilution that Rungsima showed. And I think there are very nice results. If we have some time, I'm going to share a few slides and I'm going to show you the results.
Okay, so let's go for that. Let's go for that. In the meantime, yeah, because we don't have time. So I think it's nice if you can share that with us.
See if I can. How do you do it? All right, share. Do you see it?
Yeah, we see it.
All right, so let's just, I'll share some, it's off-label. Some of them were published, and actually it's not Xeomin, so it's other brand, but because we talk about energy-based device-assisted delivery, so if it's 150 kilodalton, I do believe, and this is probably the next study that we should do, so we should compare 150 kilodalton Xeomin as compared to, let's say, 900 kilodalton of Dysport. I think probably the delivery will be better. So I'll just show you one case. So this is a patient that this is a rosacea. She was resistant to any modality. Actually, she shared these studies with me, and she told me that maybe the injection of botulinum toxin would assist her. Why? There are few publications, probably because of the blockage of the of the nervous system, the autonomic nervous system, and the cutaneous vasodilatation system. What we did, so she didn't want to be injected. What we did in this case, but probably it could have been done with CO2 or radiofrequency. Here it was Tixel. So we did 2 treatment. Please have a look, and I will show you the pictures. Again, I did it very short, but what you can see, this is the erythema index, and you can see the clinician erythema assessment score. So this is baseline. This is 1 month after 2 treatment, and you can see that there is a very, very dramatic effect.
Yeah.
I'll show you the results. So this is the before. This is 1 month post 2 treatment, and this is 6 months post treatment. And again, very, very nice result. And I have to say that now it became my kind of standard of care. So for the resistant rosacea, I do use either micro injection or some, I would say, energy-based device-assisted delivery of botulinum toxin. I still do not have experience with Xeomin, so the rationale of 150 kilodalton probably, I think it would be very beneficial. This is, again, there are not many dermatologists, but using the same idea. We used Tixel followed botulinum toxin for the treatment of, this is Haley. This is a very, very stubborn and aggressive disease. It has blisters, especially in the axilla and the inguinal area. And again, this is it ruins their life. So this is you can see you can inject toxin. There are publications regarding the injection of botulinum toxin. And again, this is with drug delivery, and Xeomin, I believe, will be very beneficial here. I want to talk to you about, this is in Hebrew, but you can see it. But I want to talk to you about scars. So scars, in general, we treat with many modalities. If you want to maximize your treatment, you do have to combine between different modalities. So here I would not get to all modalities, but here we first improve the skin quality and we restored the lip. This is micropigmentation. But, and this is very important, especially in the area of hyperkinesis, so especially the chin, the forehead, botulinum toxin, this is part of the treatment. This is again part of the publication of Rungsima. So I do think, so on the one hand, it normalizes fibroblast proliferation and collagen fiber synthesis, and on the other hand, it just relaxes the myofibroblast, and then you reduce the tensile force. You will have better aesthetic outcome. Keloids, I have to say that this is very controversial regarding the use of botulinum toxin, though, especially in keloids in the chest. So we use lots of devices and lots of drugs, mainly 5-FU and steroids. But I'm not sure you can see my cursor, but usually on the border of the keloid, I inject drops of botulinum toxin in order again to reduce the tensile force. From my experience, it is beneficial. And the last slide that I want to share with you, please have a look at the neck. So regarding what we call thin skin, so it can be the arms, so the forearms, it can be the necks, it's actually mostly the neck. I don't know about your strategy, Jani, and what you do with neck patient. Neck is a problematic area to treat, but from my experience, if you don't go to surgery, you have to combine between a filler. Mostly what I use is calcium hydroxyapatite, so I hyperdilute radius, and I use it with an energy-based device. I know that it was published for different area with therapy. I like radiofrequency, but my technique, and again, this is the reason we talked about it with the publication of Rungsima, I usually use the 100 unit, I use it with botulinum toxin, but 100 unit with 6 cc of diluted something. So usually it's radius with lidocaine and saline, but we injected, so 6 cc to one side and 6 cc to the other side, and we have very nice. So first, of course, it relaxes the platysma. This is part of the clinical picture, but I think it has some additive value in stimulating fibroblast, again, collagen production, and I have better aesthetic outcome if I combine. So again, I think, and let me stop. How do you, okay, you do it like this. So I have to say, can you hear me?
Sorry, okay. I should switch my mic on.
So what I said, that it's like, again, you know, botulinum toxin, this is an ancient medication used in many areas and for many indications. Mm-hmm. So you know, we talked. You mentioned the labeled. We didn't mention the, you know, the mentalis and the masseter and the platysma. We can't really cover everything. There are there are many off-label indication, and I think we're very. So we exceeded 1 hour.
Yeah.
The Israeli market is ready for another toxin.
Yes, I think so. And, you know, I have been putting a lot of time into making very schematic illustrations of exactly where to put the amount of units, you know, in all these protocols. And I've been putting them into an ebook. Mm-hmm. And it's almost finished. Actually, I wanted to present it today, but the designers they couldn't make the deadline. So sorry about that, guys. And also, I haven't decided on. I don't know how much I should charge for an ebook like that. how much you think it would be, a good price for like an Apple ebook with videos inside and all these protocols? What do you think I should charge for that?
Yanni, I have no idea, but I will pay whatever you demand. Okay.
Let's just ask the people here in the room. How much would you pay for it? Would you pay? Would it be definitely less than 100 or between 100 and 150? Like, how much would you pay for it? Seriously, I'm just like asking. 100% less than 100. Of course, it's Israelis. Oh no, actually, some are more like you. Yeah, exactly. But nobody would pay more than 150. Yeah. All right. So that's a good indication for me. I'm gonna try and make it attractive for you guys. It's almost done. And if you send me an email or a because I need your email address actually, or if you follow me on Instagram, then send me a private message. Then I will let you know whenever it's published.
So we're excited. So there is another toxin to play with.
Mm-hmm.
And every product, not just toxin that gets into the market, I'm talking about the Israeli market, but in general into the market. So we start playing, and then we have many ideas and many indications. This is the fun business. Maybe we will leave time for 2-3 questions, like burning questions. I don't see it, so maybe you see.
Yeah, they're in the chat, and actually, let's see. There's not too many questions. There's actually somebody who wanted to speak. Ora and Marina. Let's see if they're still there. I think maybe we don't have enough time. Maybe if we can just put some questions in. If you have a question, just put it in the chat. There is a little bit of delay, I know. We get a lot of hellos, actually. Oren says 199, 199. That's good. What? Oh yeah, and actually, that's what I wanted to ask you too. The dose and the dilution ratio for the rosacea.
We did it. I think in the study, it was Dysport. It was so now let's say if we use in the study was done. I have to say that in my clinic usually nowadays I use mostly Botox. And what I do, I use 30 units, international units in 3 cc's, and I just apply and reapply. I can't really explain, but after 1 treatment there is very minor change, but after 2 treatments there is quite dramatic change. Nowadays the protocol, what I do, we combine it with a vascular laser. So we do either an IPL or pulse dye laser, or we have a Asclepion 577 followed by this Tixel. Tixel just decompose the stratum corneum. It just enhances drug delivery, and then I apply it, and I have a very nice result.
And why do you think that it reduces rosacea?
It's a good question. So let's start with the toxin. So the toxin, I think it has inhibitory effect on many, I would say, cutaneous system. Many of them we are not familiar, or we still do not know. But one of the speculation that it blocks the connection between the nervous system and the vasodilatation. Then you have less vasodilatation, and this is a phenomena that you see in rosacea. I do have to say that while taking all this, I would say, combined approach, so, the IPL and the Tixel, this is heat. So probably it decreases. I skipped this slide, but there is a decrease in the Demodex folliculorum culture. So maybe this is one of the reason for the improvement. IPL or all the vascular, it closes the blood vessel, but this combined approach, I think it is the longevity. I have now more than 200 patients, and I have follow-up of more than 2 years,
Mhm.
there is some change in the disease. I can't really say what.
Mhm.
So nowadays we do these 3 treatments, and then we do every half a year we do a maintenance treatment.
Right. There's a few questions here. What about headaches? Do you see headaches after treatment? Well, I have heard of it like maybe once in the last few years, so it is not very common. I think
No, I do encounter it, and I do have to say that it's like for some reason, again, it wasn't shown. I think it is related to forehead
yeah,
injection. So
and maybe
whenever
periosteum or something.
yeah, I don't know why, but it's like so it's again, it's not very common, but I did encounter it. And whenever the patient is coming, so they're not complaining, they're coming for the next toxin injection, and then they're telling me, look, we were very satisfied with the result, but I have to tell you, in the first month, it was horrible. I had such a headache. So usually I skip the forehead. I do just the glabella and the crow's feet, and usually it doesn't recur.
Okay, there's another question. Can I rewatch the webinar? Yes, I will make sure there's going to be a replay on my website. So it's going to be free for the next few days. After that, it will be payable, but it's going to be free for the next few days. My website, janivandloghem.com. What about the glabella? How many units per injection points? And the headache treatment. All right, so there's 2 more things. Okay, let me just quickly show you the this one, glabella basic protocol. Do you see this?
Mm-hmm.
All right, so basically the five injection points are 4 units each, right? And that is the basic 20 unit standard dose for Xeomin. And then it's of course based also on the location of the neuromuscular end plate. So the Procerus has basically 2 bellies. You inject right here, then you reach both of these high concentration neuromuscular end plates. Also,
but again, you have to look at your patient. It's the same like Botox, the same injection. Look at your patient.
exactly.
Ask them to frown. Sometimes if you just use 3 points, so the 2 medial injection and the one on the Procerus, it's enough. Try to have a look if you have a strong muscle or you have a weak muscle. It's better to you try to study your patient, so you can do if it's the first time, you can do it with a minimal dose and then increase as needed.
So this patient, for example, I skipped the Procerus because he doesn't show any Procerus. So and as you can see, so I'm just a little bit medial to that dimple. You see here this corrugator dimple, which is the lateral skin insertion, and just medial to that, I just give, and then just here, this one is deeper. This one is more superficial. So the medial injection is deep, and the lateral one is superficial.
So my technique is a little bit is different. What I do with the medial part, I usually go deep. I inject 2/3 of the quantity, and then I inject another third a little bit more superficially. And if you go back to the last slide, you see that you have some like concave, I would say. So when she frowns, you have this. So I inject from the side. So I'm getting to the same point. So I'm very superficial, and I'm injecting slowly. And I think I have, again, it wasn't proven, but I think that since I'm using this technique, I have less ptosis.
Yeah. Actually, that video I haven't included in this presentation somehow, but I also use a needle. I go in from here, and I advance the entire needle, and I do a retrograde linear thread with the 4 units.
Do you use 30 gauge needle or 32 gauge needle?
I usually use the, I think there are 34 now, the TSK
Really?
visible needle, yeah.
So maybe we have it. I don't know, but it's like the 30 are painful. So if you want to really, and it was shown again in another study. So if you want to kind of make it less painful, so just go to 32. If you're 34, I'm not sure they exist in Israel.
Let me see where I have that one. No, that is, wait, that is masseter muscle. Where is that tension headache? I've lost it.
Jani, I think we are losing people, so I think we have to conclude.
I think so too.
So what can I say? It was great meeting you virtually. If we don't meet in Kuala Lumpur, I don't know how many conferences we missed with this corona.
So sorry guys, because I see all these questions. What is your dose for masseter injection? How many days after injection, no workout? Oh, that is maybe like one little question we can answer. What is aftercare? My answer, there is no aftercare.
Oh, I'm shocked that you're saying it. That is what I think. It's all, I'm not sure we're allowed to say it, but I think it's all bullshit.
That's what I mean. I mean, everything is well meant, but not proven. So, and I have made the mistake once that I got my toxin injection, and I forgot about it. Immediately, I went for a massage. You know, I was laying on top of this circular pillow, and nothing happened.
Yeah.
I
always run after I do my toxin, and I do all the forbidden. So generally speaking, again, we have some instructions, but none of them were really proven. But I don't know, we need some brave, Jani, you're brave. We need some brave person to study it and to do, I don't know, a retrospective study showing that you can just go back to your normal life. Last question, Jani.
Last question. Okay. Okay. So all the dosages are going to be in the book. So like, just buy my book, and the answers are there. And here it says when effects suggest, and when side effects happen, do you suggest any more neurotoxin injections in the future? And if yes, how far and by what protocols?
But what side effect?
Yeah, I think maybe if you have a drop of the brow, of course you have to inject toxin to raise it again. But maybe she means neutralizing antibodies or something. Would you inject them? Okay, we pick another one.
But let's say that if you do have ptosis, this is not contraindication for re-injection. Just be very careful. Again, you have to differentiate between I would say there are different types of ptosis, so you have to differentiate and try to go in your next session, go more slowly, go with lower dose, if the patient will let you treat her after ptosis.
Yeah. And then is it not better, and I think this one's for you, to inject first toxin in the neck and then after that radius dilute for the neck? Or because is the effect of mixing the same like injection first and then the other product?
It's a good question. So whenever I do either phenol peel or CO2 laser resurfacing, I usually do it before. So I want them to come to the procedure when the tensile force is really the lowest. But while talking about the neck, we do it the same procedure. We do the energy-based device, the radius, and the toxin together. But again, you have to understand, I'm not talking about the platysma. So it's like, if we talk about true platysmal band, probably I would have you just hold it and you inject. I'm talking about, again, fibroblast. I mean, if you're interested in this concept, so just Google or write in PubMed. It was written by Rungsima from Bangkok, and she showed that you have some fibroblast stimulation. So we know that probably the toxin, it stimulate, it normalize fibroblast stimulation or collagen fiber production. So again, the rationale to use the radius, the hyperdiluted radius with botulinum toxin is not to actually smoothen or to relax the muscle, is to induce collagen production.
Exactly.
So we do it the same treatment.
And
But I don't want to see the patient so many times.
there's one last one from Oren. What about reference to the internal tissue? What is the blood and hormones picture? Providing matching hormones from a natural source a great effect on the facial tissue? And what about considering the psyche that also has a huge impact on the texture of the bone and muscle tissue of the facial tissue?
I didn't get. But if, okay, I don't know on what you meant, but if I understood correctly, again, it's like we're talking about the anatomy of aging and aging in general.
Yeah.
Toxin is just a fraction of treatment. So it's always when you look at, when we look at our patients, so there are few processes. There is volume depletion, there is skin quality deterioration, there is loosening of connective tissue, of the retaining ligament, and we have what we call dynamic or hyperkinetic condition. You can see it with the peau d'orange, so you can see it in the chin, you can see it in different areas. So these conditions can be treated with toxin, but it's just a fraction of the treatment.
Exactly.
I'm not sure if this was the question. So,
well, yeah, of course, you have to consider the patient as a whole, not just as a target for toxin.
yeah.
Yeah, I think that's a great moment, I think, to close. We've overrun time half an hour, and
Yeah.
I think thank you for staying with us, for being with us for such a long time, hour and a half, talking about Xeomin. And of course, we haven't covered everything yet. We could spend at least a whole day talking about all the little details and talking about all the injection techniques. But I think this is a good start, and based on this start, you should go ahead and play with it. And it is like getting a new girlfriend. I mean, if you're
Boyfriend.
or boyfriend, it's like getting a new boyfriend. I mean, if you're used to the old one, right, with his nice characteristics and with his problems, and then you get a new one, you have different problems and different nice things, and you just have to get to know each other.
Yeah, after 19 years of relationship. Yeah, it was great having this webinar with you. So I wish you the best, and I hope I will see you soon in flesh.
I hope so too. Maybe Monaco.
Yeah, a big hug. And hello everyone, shalom lekulam. Bye bye.
Shalom, shalom. Bye. Laila tov.
Laila tov.